This is normal, healthy blood flow. Smooth, regulated, and constant. But the moment bacteria or toxins invade, everything changes. Your body launches an immediate defense mechanism, the acute inflammation. Welcome to Dr. Pathology Hub. Today, let's uncover its pathological blueprint. Acute inflammation is a tightly orchestrated cascade divided into two main arms, vascular events and cellular events. Our goal is to trace exactly how we get from a physical injury to microscopic cellular deployment. Here is the 5 cardinal signs. Rubor and calor are driven by local vasodilation and hyperemia. Tumor represents the swelling from protein-rich exudate leaking into the interstitium. Dolor is mediated by the release of chemical messengers like bradykinin, prostaglandin, along with edema irritates the nerve endings. Finally, severe swelling and pain lead to functio laesa, loss of function, a hallmark added to the classic 4 signs by Rudolf Virchow. To understand this on the skin, look at the triple response of Lewis. A mechanical insult triggers a rapid neurovascular cascade. Step 1 is the red line, appearing within seconds due to localized capillary dilation from direct mast cell histamine release. Step 2 is the flare, a bright red irregular halo spreading outward via an axon reflex that dilates adjacent arterioles. Step 3 is the wheal, a pale, elevated patch of localized edema pushing the skin upward as fluid escapes the leaky microvasculature. Under the surface, the hemodynamic cascade follows a strict, predictable order. The very first response is a fleeting, neurogenic, transient vasoconstriction, lasting only seconds to minutes. This is instantly overridden by progressive vasodilation mediated by histamine and nitric oxide, opening new capillary beds. As a result, vascular permeability increases, allowing fluid to escape. This massive fluid loss leaves behind concentrated RBCs, causing blood flow to drastically slow down, a state known as stasis. Let's look closer at the mechanics. In a normal resting state, precapillary sphincters restrict flow, forcing blood to bypass most tissue beds. During acute inflammation, histamine and nitric oxide relax this vascular smooth muscle. Microvascular blood flow surges up to 10-fold, a state of active hyperemia that serves as the true engine for local redness, rubor, and heat, calor. How does the swelling happen? The primary driver is endothelial retraction. Inflammatory mediators bind to specific endothelial receptors, causing the cells to undergo cytoskeletal contraction. This physically widens the intercellular junctions, creating gaps. Intravascular fluid, plasma proteins, and eventually leukocytes leak directly into the extravascular space, presenting clinically as tumor. For your competitive exams, you must differentiate the 2 types of edema fluid: transudate versus exudate. Transudate occurs across an intact endothelium due to increased hydrostatic or decreased oncotic pressure. It is protein-poor, cell-poor, and has a low specific gravity below 1.012. Transudate could be seen in conditions like chronic liver diseases, renal failure, and congestive heart failure. Exudate, the signature of acute inflammation, occurs through a leaky, inflamed endothelium. It is highly protein-rich, packed with leukocytes, and features a high specific gravity greater than 1.020. As fluid pours out to form that exudate, hemoconcentration takes over. The remaining blood becomes incredibly thick and viscous. This causes blood velocity to decelerate rapidly into stasis. This disruption of normal laminar flow is a crucial turning point. It forces the heavier white blood cells out of the central axial stream, pushing them directly against the endothelial walls. This process is called margination. With the cells marginated, the cellular pathway unfolds across 5 distinct phases. Phase 1 is margination, where cells line up along the periphery. Phase 2 is rolling, where cells tumble along the wall. Phase 3 is adhesion, where they anchor firmly. Phase 4 is transmigration or diapedesis, where they squeeze through the endothelial gaps, leading to phase 5, chemotaxis, crawling through the tissue toward the enemy. Let's zoom into phase 2, rolling. This is a transient, low-affinity interaction that acts like speed bumps for fast-moving leukocytes. The endothelial lock consists of E-selectin and P-selectin. The leukocyte key is sialyl Lewis X. Their rapid binding and detaching allow the cell to slowly roll along the vessel wall, scanning for the site of injury. Rolling stops when high-affinity bonds take over during firm adhesion. Leukocyte integrins, like LFA1 and MAC1, lock onto endothelial ligands, ICAM1 and VCAM1. Once anchored, the cell undergoes transmigration. Flattening out, it squeezes through interendothelial gaps, driven primarily by PCAM1, CD31 interactions present on both the leukocyte and the endothelial cell margins. High-yield exam pearl. A genetic deficiency in the CD18 integrin chain means cells can roll but can never firmly adhere, causing leukocyte adhesion deficiency type 1, LAD1, marked by severe neutrophilia but zero pus formation at infection sites. To summarize everything we've covered, acute inflammation is a perfectly sequenced progression. Hyperemia widens the vessels to cause rubor and Cellular. Endothelial gaps lead to fluid exudation, creating tumor. Released mediators sensitize nerves, generating dolor. Together, this vascular defense and precise cellular deployment manifest as the 5 cardinal signs. Thanks for watching. Drop your questions in the comments, hit the subscribe button, and I'll see you in the next Pathology Breakdown.